Good afternoon. Can everyone hear me okay? Yep. Okay, let me first introduce myself. My name is Major Bev Sapre. I'm a medical officer serving with 208 Field Hospital, but in my civilian job, civilian life, I'm a consultant psychiatrist in general adult psychiatry across the water at Cheshire and Wirral Partnership. So today, one of the topical issues I believe, and I'm sure given that you're here today, you believe so as well, I'm going to talk to you about battle shock, where we were at the time of World War I, and today, as we know it, PTSD. Topical issue insofar as mental health difficulties have been well recognised as being part and parcel of medical problems that our men and women have suffered during wars dating back to ancient times. But really, it's only been in the last 100 or 200 years or so that we've really started to have real recognition of what these sorts of mental illnesses are. And we've learned a lot from particularly World War I and II. And really, we've hopefully, I'd say, through this presentation, you'll gained a lot of knowledge and progressed in the sorts of treatments and things we can offer our men and women who serve. Okay, I'm going to start off with giving you an example, showing you a short video of a story of an officer called Angelo RAMC. He was someone who served in the American Civil War. And although the term battle shock was never used at that time, certainly there was clear understanding that mental health difficulties happened in that particular war because of the sheer scale of trauma and devastation that the men saw. So I'll just let you see this video because it's one of the earlier documented cases of mental distress.
I found him lying on the ground on his back. His gun was between his legs, muzzle on his breast.
I remember that when my brother Angelo came home from the army, he looked wild. And when he was raving, it took my father, mother, and half-sister to tie him down to the bed.
It seemed that something he did in the army preyed upon his mind and wounded him.
He seemed to be worried, and he said everybody hated him because he had killed people.
If ever a man's mental disorder was caused by hardships endured in the service of his country, this was the case with my son.
I loved no one of my men more than I did Angelo. He came up to my ideal of the youthful patriot, the heroic American soldier.
Okay, so just to illustrate there, that was a description of someone who'd experienced great mental distress, having served, with no real recognition of what that was, what treatment he required, and because of that, really resulting, unfortunately, to his unfortunate death. And historically, we've really understood very little about trauma and the effect it's had on men who served. And because we understood little, very little was actually done to try and prevent it. So over the centuries, we found that this mass exposure to really traumatizing events clearly had an impact on the minds of people, but it wasn't really until a little bit later on that we decided that we really needed to do something. And that brings me on to the next slide. So I'm going to, for the first time, use the word shell shock because it was in World War I that this term was used for the first time. I'm just reading this slide here because this is a description of what Dr. C. Myers, a military psychologist, stroke neurologist, had seen at one of the base hospitals in France in February 1915. So immediately after one of the shells burst in front of him, his sight, he said, behind came blurred. Another shell, which then burst behind him, gave him a greater shock, like a punch on the head without any pain after it. The shell in front cut his haversack clean away and bruised his side. Now, C.S. Myers met this soldier and was really perplexed at the presentation. He examined him, he assessed him, and found no obvious physical injury as to why this man should experience blindness in the way that he was experiencing. So he investigated further, and as time went on, he found these unusual cases of men describing great debility from a physical symptom, but he could not find a cause. And that led him on to actually publish a paper in the Lancet back in 1915, which described shell shock for the first time. Shell shock was a very good term because it really described exactly what was going on then at the time. A man had experienced persistent bombardment of shells in his close vicinity, and it seemed his body had experienced a shock. And at the time, he drew some hypotheses as to what that was about. Why would someone who'd experienced shell shock, why would he have a physical presentation as such? And he believed that there was some degree of micro-hemorrhage or trauma that the man was experiencing, which medical professionals at the time could not actually identify. Shell shock, although explained a lot, equally was a bit of a misnomer, because although he could explain shell shock in individuals who had been exposed to persistent shelling in their close vicinity, he equally found that many men would experience symptoms of shell shock who'd never even been to the front line. Or if they had, they would experience the trauma of the front line for very short periods of time. So although it described a lot, it raised a lot of questions at the same time. Now, a lot of doctors as well during that time were trying to understand in other ways what sort of illness shell shock was. C.S. Myers talked about shell shock in a physical sort of term, but there were many doctors who described it as a type of hysterical conversion. Now, for those of you who have any understanding of kind of mental health services and the terminology we use, hysteria was always previously something always described as something that women experienced, from the term hysteria being the Greek word for the womb, so some sort of problem in the womb. So many of the people who were described as hysterical prior to World War I were always felt to be women. So how, for the first time, are men being described as hysterical? And it became a term that had really quite a negative connotation. So they stopped using the word hysterical to calling it conversion disorder. And what conversion disorder, which is a term we still use in psychiatry today, is an individual, the trauma that they experience or suffering that they experience in a psychological way has a physical manifestation. And that was another hypothesis, physical versus psychological. Just to present a few statistics to you, these were shell shock, and the statistics around shell shock are very variable if you look through the literature. Because I guess looking back at that time, looking at the accounts, how shell shock was being diagnosed and what it was actually being, whether it was correctly diagnosed at various points, was very much up for debate. And if you look at the plethora of information out there, you'll read very, very different amounts of data with very, very different conclusions as to how much was described then. But as such, shell shock was felt to be something of an epidemic. And it was actually thought in a number of instances really to be a contagious condition. So if one man in your platoon was shell-shocked, you wanted to get him out quickly, out of the way before the others caught the condition as well. What we do know is that at the Battle of Somme, 35,000 men broke down. Now, whether that was shell shock or not, or something else, but it was epidemic. And the military couldn't ignore this condition. So shell shock, I've listed a few of the alternative terminology that was used before shell shock and even afterwards. Battle fatigue and combat fatigue or exhaustion, which I'll describe later, were more terms used during World War II, and I'll explain the reason why those terms were used rather than shell shock. It's also war neurosis and railway spine. These were other conditions which were described in similar ways. Just to explain what railway spine actually is here, railway spine was something which was termed back at the end of the 19th century. And at that time, where industrialization was taking place at an immense rate, many workers who worked on the railways would experience physical symptoms, either as a result of the work that they were doing or because they experienced some sort of traumatic event, watching a colleague die during the construction of the railways, because there were loads of hazards associated with the construction of our railways. And many people describe physical symptoms, but with no physical actual evidence of there being a problem. And again, this is where, at this point, compensation culture had just started for the first time. And there was a lot of debate between the medical professions at the time about whether railway spine was an actual physical condition or something to do with malingering and compensation. And in fact, some medics actually called it compensation neurosis, which never really was popular as a term, hence railway spine was used. So going on to what we learned from World War I, there's clearly a lot of information out there and lots of evidence that men were being driven to madness as a result of what traumatic things they were seeing. And shell shock was described for the first time. Now, World War I, compared to the many historical conflicts we've experienced as a civilization, was very different in that it was a very industrialized type of war. Men, for the first time, were in fixed positions, experiencing serial bombardment using high explosive pyrotechnics, and this just had not been something that, as a civilization, as human beings, we'd really encountered before in previous wars. When men did come back from the front, clearly traumatized, was this a psychological condition? Was this a physical condition? Nobody really knew, and it left doctors and nurses with a free hand really to do whatever they liked in terms of treatments, because people really didn't know, the military didn't know what to do with these individuals. Given that there was a debate between it being physical or psychological, there was the stigma that went along with being told it was a psychological problem. What the military were keen to do was, they could see these men were impaired, unable to go back to the front, so they really wanted to do something about it. And this was really where a lot of the psychological therapies we use today in psychiatry, they were born during this era. So we have to almost credit these events for some of the developments that we see today, because the military were really put in a position where they really had to do something about it. So specialist hospitals were actually open during this time, and the Tavistock Clinic still exists today in London, and they pioneered a lot of the psychological work that we now use today in mainstream civilian psychiatry as well. So just to move on to another quick video as well, for you just to get a bit of a summary of what I've just described.
In February 1915, he reported his findings to the Lancet and concluded that the bursting of a shell had caused an invisibly fine molecular commotion in the soldier's brain. In other words, a physical shock to the nervous system had caused the strange symptoms. From this, he coined the term shell shock.
I suppose shell shock made much sense. It captured exactly what was happening. There were lots of shells around, there was lots of blast, lots of shock, and people, after being blown up or buried after being blown up, were in a state of shock. So I think it was a wonderful term because it described it quite perfectly.
To the Army's alarm, more and more cases of shell shock began to appear. After just 6 months of war, 15% of the British Army was judged to be suffering from the condition. The most extreme cases were blind, deaf, mute, or shaking, yet all without an apparent cause, other than their proximity to bombardment. Similar cases appeared in the French and German armies on the Western Front.
The shell shock are the symptoms of a mental person. All the signs and symptoms, shaking, head shaking, hands shaking, body shaking. They were, in other words, they weren't themselves. They had to be nursed, taken to the toilets and all that sort of business. They weren't fit to be left on their own. I mean to say, if you had a few shells bursting round you, you wouldn't feel so happy, would you?
Okay, lovely clip there. And he's really described quite well some of the symptoms that men described in that small clip there. Now, the range of symptoms you could experience with shell shock were really varied. These were just some of the ones described in the beginning, in the initial descriptions, like sudden muteness, deafness and tremors. But in one of the pictures you would have just seen in that little clip there, the man with a rather unusual gait, men would come back looking really quite odd, which is why people thought they must have been putting it on. There was one type of gait called hysterical dancing gait, because the man would just jump up and down as he was walking. There was walking in the wind gait, because he looked like literally there was a gust of wind and he wasn't able to move forward. Slippery ice skate gait. You know, these are really well kind of put together in terms of a description of what was seen, but almost made it quite comical. So it really left the medical professional still being able to describe what they saw, but really struggling to put it together in a way that made sense and actually could gain a bit of respect from other professions as well. Okay, so in terms of treatment options, like I mentioned, doctors had a free hand to try whatever treatments they wanted. The military were really at a loss at the sheer scale of problems that they were seeing within their soldiers. And across the ranks, officers and soldiers alike, they were really seeing a lot of difficulties. So the sorts of treatment options that were really looked at didn't just apply to our men within the British and Commonwealth forces, but German, French, they saw the same sort of casualties. And some of the treatment options that they pioneered, we also actually adopted later on. So for example, in France, they used a treatment called Faradayization, coming from Michael Faraday. What they would do, they would confront these men who were experiencing physical symptoms, so would say, my limb doesn't work, my arm doesn't work, my leg doesn't work. Now, they would then say to them, right, I'm just going to stimulate that part of your body, would apply a small electric current, and invariably they'd have experience of a physical experience from being electrocuted. And then they would say, well, look, your arm does still work, your leg does still work. So it was almost a form of confrontation type of treatment. But reading the literature, it did actually work in a lot of cases, so it was used quite widely. The Germans, on the other hand, were more fans of hypnosis. And certainly, again, that was a form of therapy which we used here with varying degrees of success. During this time as well, this was very much the era of Freud. You know, he was really coming into his own at this point. And looking at psychotherapies and talking type therapies, we were using them for the first time. These were seen as quite woolly options, and the sheer scale of numbers of people that were actually coming forward with problems, psychotherapy was a bit too much of a luxury that we couldn't afford, because psychotherapy takes time. It takes a lot of time to actually sit down, talk to someone, give them therapy, and on the sheer scales of numbers that we were dealing with, there wasn't always a luxury to do that. But nonetheless, a lot of things were done. Moss Side Military Hospital in Mughal, interestingly enough, most people might not be aware, was actually one of the first places in the UK, military hospitals, to do dream analysis. And this was a very Freudian concept around looking at, well, the theory was that men would repress these negative experiences and they would come to the fore in their dreams. And by analysing them, you cured them of that, the distress associated with those experiences. And the Mughal doctors did really well with it. They had some very good results. I think doctors at that time were really in a quandary and experienced a great deal of internal conflict in that they would treat these men successfully, but then they had in the knowledge that they would have to send them back to the front line. So through these types of treatments, these doctors developed a great empathy for their patients, and they really struggled with having to make decisions as to deciding who was suitable to go to the front line again. And this was the point at which the army as well, for the first time, understood that they really needed to think about the selection process. Obviously, in the advent of such a war of its nature, we didn't have the luxury of selection, but it was something that was really recognized, that people had a personality or a disposition that would make them more likely to suffer from psychological distress than maybe than the next person. But some of the principles that they applied to treatments back then still apply today. We know that if a soldier, even today in conflict, experiences a traumatic breakdown of any sort, ideally you want to treat them at the front. You don't want to medically evacuate them. You want to keep them in their environment as best you can, if that's possible. Because to take them away often is associated with guilt, with humiliation, and a whole host of other emotions, which can be quite negative. Military men certainly do much better within their own hierarchical environment. To take them away, put them in a civilian environment, they often feel out of place and feel less understood. And that structure that the military provide is often very protective to them as well. So on the whole, evacuation was avoided and people were kept at the front as best they could. And also it meant that we didn't deplete our troops quite so quickly. I've used the word battle shock quite a lot, but this was a diagnosis because of the nature of its description as being something possibly psychological, also something to suggest that someone was weak, meant that it was often reserved for the soldier on the ground. When an officer had a breakdown, well, he wasn't described as having battle shock. He was described as having a condition called neurasthenia. And that somehow was a bit more palatable to the officer class because they saw themselves as leaders of men. They were expected to be strong for their troops. And therefore, battle shock wasn't an acceptable term for them. So neurasthenia was used, which basically means nervous exhaustion, essentially. Pretty much the same condition, but with a more palatable description. And from that, we also found that keeping officers and soldiers together in the same clinical environment, should they be taken from the front, wasn't a helpful thing, particularly for the officers. So specific hospitals for the officers were actually made. And one of those was Craig Lockhart Hospital, which is probably well known to maybe some of you, in Edinburgh. This was where the officer classes went, and they received a lot of treatment of a rehabilitation nature, which again was very new to psychiatry, that you could mentally rehabilitate. We talked about physical rehabilitation, but mental rehabilitation was quite a new concept. And many famous officers actually went there for treatment. Wilfred Owen being one of them, he had treatment there. And Dr. Rivers, who was one of the main doctors there, he had real belief in psychoanalysis. He did a lot of psychoanalytical work with the men out there. And you know, the place was deemed a real success overall. But despite that, one of the things which senior ranks within the military would still say would be the majority of men, especially in this country, are healthy and devoid of any interest in psychiatry, which is regarded a queer interest for queer people. So clearly still, despite the fact that the military had recognised battle shock and mental disorders related to warfare, there was still this stigma attached. And just to go back to the key principles, which even today apply of treatment, is immediacy. We wanted shell shock or any conditions to be understood as just an acute illness that could quickly be treated and that wouldn't become chronic. Proximity, keeping the treatment at the front line. Expectancy. Now this talks about hope and instilling hope. And even at that stage back in World War I, there was a lot of understanding about making men feel that they could get better and instilling hope. And that's what the medics did on the front line. Simplicity. The treatment options that they had at the front were very simple. They couldn't have fancy drugs, fancy psychotherapies, or fancy environments for them to be in. It was very much about feeding them, giving them rest, and very basic types of psychological support. And centrality was about keeping things consistent across the board, across the hierarchies. So moving on to World War II. Now, sadly, a lot of the lessons learned from World War I were forgotten just 20 years later for World War II. But one thing which was really emphasised quite early on and pushed not by the Ministry of Defence but by the Ministry of Pensions was the need for a clear diagnosis and a clear understanding of what war neurosis was. This was on the back of the fact that after World War I, over 120,000 men were receiving war pensions because of psychological trauma. And that was a hefty burden to the taxpayer. So the Ministry of Pension actually employed an expert psychiatrist, Dr. Prydu, who looked back at the 1922 War Office Committee on Shell Shock and actually drew up some conclusions and some recommendations, which were probably, politically and at times popular or unpopular, depending on which circles it was disseminated. But what he found was men who received a war pension and were deemed mentally disturbed or unable to function had a poorer prognosis than men who actually who didn't receive a pension at all and were asked to get on with it, essentially. And this is where, for one of the first times, they really started to question whether giving people a diagnosis, giving them a pension, disabled them because it allowed them to be in a sick role. It almost gave them permission. Society gave them permission to be unwell. And the psychological effects were that this person then became a member of society that wasn't contributing. So this is why they wanted to really look at the diagnosis. So it came from this angle, from the Ministry of Pensions rather than anywhere else. And this was the first time as well that constitutional predisposition was talked about. I mentioned earlier about personalities. The military were very keen to try and weed out the men who were possibly not suited to frontline warfare and maybe give them jobs which meant they didn't have that exposure. This was an ideal situation because, again, in World War II, the need for manpower was so great that selection process, although the military did do psychometric tests for the first time, it didn't really happen quite in the way that the psychiatrists would have liked. And so from then, really, the selection process did happen, but it's more of a recognition than something that really happened properly. So what happened during World War I? Well, there was a naive belief that battle shock was over and done with in World War I. It won't happen again. We're going to do things differently. We're going to select our men appropriately. But unfortunately, the Battle of Dunkirk showed otherwise. We literally had a flood of traumatized men coming back, not able to go back to the front, just by the sheer scale of devastation that they witnessed. And many of these men were admitted to civilian hospitals, psychiatric asylums at the time, and the military weren't entirely satisfied that these men were being processed quickly enough, as they put it. They wanted them back out the front as soon as possible. So the military thought, we really need to do something about this. Now, at the end of World War I, recommendations were that medical officers serving should have specialist skills in psychiatric treatment. But by the time World War II came around, there was only 6 such suitably trained doctors in the military. So there was suddenly this need to sort out the treatment options that we had. So over 200 psychiatrists were employed by the MOD. Specific military psychiatric units were opened, including Northfield. And this was in order to actually process the men a lot more quickly. We needed them back out the front quicker than what the civilian institutions were doing. But a lot of the work that was done in Northfield was really pioneering stuff, which even today we still use. ECT, electroconvulsive therapy for depression, art therapy, which even exists today in the NICE guidelines for recommended treatments for schizophrenia. And for the first time, medication was introduced to the treatment of men. There was slightly more of a move away from the psychological treatments because it was all about getting people well very quickly. So what sorts of medical treatments were used? Well, stuff which ethically we wouldn't dream of using today. Because the term battle shock wasn't used, it was combat fatigue or combat exhaustion. These were more desirable terms for the simple reason there was something about them that suggested they were short-term and also reversible, whereas battle shock was seen as something that wasn't reversible. And these terms also suggested that there was something physical about it as well. So it was, again, a more palatable diagnosis. But because it was exhaustion or fatigue, what did these men need? Rest. So exhaustion centres were actually set up. And even within the military hospitals, they'd have these long sedation periods where men were given medication to sedate them for long periods at a time, maybe 3 weeks at a time. Other controversial things they did, really, which now we wouldn't dream of doing, was giving them large doses of injections of insulin to bulk them up. A lot of men probably didn't survive the treatment because these were dangerous doses of medication they were using. But like I said before, psychiatrists had a free hand to try anything because there was a desperate need to get men back out on the front. These medications were used in conjunction with other treatments, and something called narcoanalysis was used. You might have heard of medication called truth serum, often described as something which the special forces might use to get someone to talk. Well, that was actually used in these military hospitals. And what essentially it was, these men were given lower doses of these sedative medications, which would get them to speak, talk about the trauma. Because for a lot of these men, talking about what they'd witnessed, they really couldn't do it. And again, the belief was that these people were suppressing a lot of what their traumatic experiences were doing to them, and hence were experiencing such terrible psychiatric symptoms. So the truth serum was supposed to cause, yes? Mm-hmm. Well, alcohol, in psychiatry as a whole, alcohol's got an interesting history in terms of mental illness. Therapeutically, small doses of alcohol have often been used as a form of sedative, given to patients at night to help them sleep. But what we do know now when it comes to alcohol, abuse of alcohol is the problem, which invariably a lot of... I think your dad was clearly a very lucky case. Sorry. Your uncle, sorry, yes. Mm-hmm. Uh-huh. Alcohol, just to shortly, I'll bring that up again later on in the slides, but alcohol has generally had a very bad association with mental illness as well as physical illness, because it usually ends up in a situation where someone uses it as a poor way of coping and ends up in a situation where they're actually abusing alcohol, so drinking to excess. So unfortunately, it was never a form of treatment that was actually advocated by psychiatrists. But these men... Of course. So this truth serum was given because it was thought to, well, what we were hoping for was it cause an abreaction. So this was this cathartic release of information, this really ease with which these people could talk about their traumatic experiences. And again, there's a lot of documented cases of a lot of success from this sort of therapy. Again, we wouldn't use these sorts of therapies today, but looking back, there were some men who really attributed the success of their treatment to these sorts of therapies. The exhaustion centres, like I said, were set up, but even today, these therapies were considered so sensitive that if you look at any of the documentary evidence, either on the internet, a lot of the footage that you see of exhaustion centres, the men's faces are blacked out, even today, because it was seen as such a controversial type of treatment. And certainly men felt very ashamed that they were not far from the front, but in a centre where they were just sleeping for 3 weeks at a time. Uh-huh. Oh, in the exhaustion centres? Okay. Well, there were only certain doctors who were privy to setting up these centres. It wasn't something that was widely known within the military establishment. It wasn't just, it wasn't common knowledge, but they did exist, and only selected medical doctors were actually asked to run these centres. Oh, yes, you might well know, yes. So, despite all these treatments being pioneered and lots of them being very, very kind of useful, there was still not really much of an appetite for psychiatry within the military environment. The military had really taken on psychiatry, in a good way, in a positive way. Psychiatrists were involved in the decision-making around selection. They were involved in deciding on who was suitable for what roles. So there was clearly a big influence of psychiatrists within the military. But still, people, in the higher ranks would rather that psychiatrists at that time would not meddle. And even Winston Churchill famously said, "Why are these men coming here asking perfectly normal men and women such odd questions?" So, there was still a bit of a battle there to progress with treatment and the influence of psychiatry. So moving on from World War II, post Vietnam syndrome was kind of the next stage in the development or in the creation of the term post-traumatic stress disorder. Now, Vietnam was a very interesting war insofar as it showed how the political climate and the influence of that on war, how much that had an influence on the psychological well-being of the troops. As many of you will know, Vietnam was domestically within the US a very unpopular war. There wasn't a lot of public support in the troops going out there. A lot of these men that went out were very revved up by nature of their training to go and defeat the enemy. Well, Vietnam didn't really, unlike World War I or II, there was no real vicious enemy to go and attack. There was a lot of unhappiness within the deployed personnel in actually being there. And men came back for the first time with a condition which wasn't acute, it was chronic. Months later, much time after the actual experience of the war, was when the symptoms showed. And we also understood a lot more about what mass trauma was about within the civilian population at that time. The Holocaust, obviously the use of nuclear warfare, had shown, again, mass trauma within civilian populations who, in themselves, were experiencing post-traumatic stress as well. So the climate had greatly changed. But the Vietnam Veterans Association was very vocal when the troops came back because they got a relatively raw deal in the sorts of treatments that were made available to them when they returned from war. So it was during this time that that really post-traumatic stress was first described properly. It was described by the American Psychiatric Association with that term. But even once it was recognized, knowing what to do with these men was very difficult, because these were men who essentially came back with trauma, an experience of trauma, with symptoms linked to it, but also a multitude of other difficulties as well. Social difficulties, alcoholism was rife, breakdowns of relationships when they came back. For those who were wounded, going back to a social role where they had a degree of status, the fact that they'd lost that, all of these things were very, very influential in causing these men to suffer greatly. And so, again, for American society, a big question was left with what do we do with our men when they come back in these broken states, really? And really, as a society, we are duty-bound to do something to support them. So PTSD was first recognized in the Diagnostic and Statistic Manual of, and that was the third version back in 1980. And this is the main diagnostic manual for those of you who work within mental health services that the Americans would use for diagnosis. So the fact that it was recognized for the first time, this was very, very important. So moving on, I'm going to show you a clip. It's actually from an American documentary, so it's not soldiers from the British armies, but just to give you a bit of a flavour of the sorts of experiences and the descriptions of difficulties soldiers and officers would have on return from conflict zones.
I see the babies that were decapitated. They all had their feet cut off. That's the thing. I don't have to look at feet anymore, so I can still see their faces.
It's particularly disturbing feeling someone's heart beating from inside their body. I still wake up with horrible nightmares from that sometimes, crying and scrubbing my hands trying to get blood that's not there off.
I don't want to talk. I don't want to eat. I don't want to sleep. I don't want to move. I just want to sit in a corner and just be a vegetable.
When I came back, it was paranoia, a lot of paranoia, emotional detachment. You know, my spouse and I, you know, like had basically grown apart.
Some things you just don't want to remember. You block them out. And I've been blocking it for so long.
I couldn't pinpoint a direct day where it'd be like, oh yeah, that happened and that's what caused it. I couldn't do it. I just know that it's not the same anymore.
Never in a million years did I ever think that I would lose my mind.
Okay, I think certainly some powerful accounts of the sorts of trauma these people have experienced and the effect that it's had. Now, what is PTSD? Now, unlike battle shock and combat exhaustion, which really didn't have a proper description of what they were left quite open-ended in terms of a diagnosis, what is battle shock. PTSD does have a specific criteria, which we use today. Now, I apologize, the slide has a lot of words in it, but this is the actual description and diagnostic criteria of PTSD as per the International Classification of Disease, which all mental health professionals will use, certainly in the UK. The thing about PTSD is what we would use to describe someone with it really is it has to be a traumatic event that anyone would find traumatic. What someone can't say who has a spider phobia that they have PTSD relating to seeing a spider in their house, for example, because that's an irrational based fear, because the general population would not say that was a traumatic experience. So it has to be an experience of trauma on a scale which anyone would understandably find difficult. And for these people, it's not just about having the odd memory or every so often feeling they've thought about something they'd seen and it just being a passing thought or even an upsetting thought. It's an actual experience of reliving that experience. I tried to find a clip from a video, from an advert which was televised some years ago, which was beautifully put together, of a soldier who'd returned from conflict, was sitting in his living room, and suddenly tanks were coming into his living room, pyrotechnics going off, limbs bleeding all around him. That's what it's like for someone with PTSD. It's the actual experience of smelling, feeling that experience all over again, like it's happening right now, not just accounting for it in a kind of a way that something that happened in the past. And these can happen on a day-to-day basis, called flashbacks, or it can also happen in nightmares. And so these people don't sleep very well. And also with that, the big problem for these people, which is why socially they find it difficult to re-engage with society, is they avoid things that remind them of that traumatic experience. So if it's to do with gunfire or loud noises, they will actively do a lot of things to avoid those experiences. And that might involve not going out very often. It might involve not socializing a great deal. So it really debilitates them quite greatly. Just the last page of kind of what the PTSD symptoms, the description and the diagnostic criteria, is these people are hyper-aroused. They literally are on edge all of the time. They find on a day-to-day basis, anything can just set them off, and that's why they're on edge all the time, 24 hours a day. And with that comes a problem that they then don't sleep very well, they have anger outbursts, their personalities have changed. And it's very rare someone with PTSD will just have PTSD. They may well suffer with anxiety disorders, with depression, with alcoholism, because invariably, in order to cope, sometimes the means of coping can be going down a very destructive route, alcohol, drugs, etc. So these people are really, really debilitated and can't integrate in society in the normal fashion. Now, one thing which now I'm going to move on to is kind of what the military do today about PTSD and compare it to civilian practice, which I suppose I'm in a lucky position. I can actually compare and contrast. Unlike back in the times of World War I and II, there was a clear distinction between what the military were doing in terms of therapeutics and what in civilian practice was going on. We've brought together a lot more our types of standards of practice, so there's a bit more consistency there. And what the military do very well is provide specialist services for people with post-traumatic stress disorder in a way that sometimes in civilian practice we could learn a lot from. Arguably, lots of civilian NHS trusts will say they don't have the resources to do it, but there's still a lot that we can learn. PTSD itself as a diagnosis is actually quite a very difficult condition to diagnose. Certainly myself in my civilian practice I've assessed people who claim to be victims of trauma relating to they're refugees and asylum seekers, so back wherever it is they've come from, whether it be Congo or any other conflict zone, have claimed they've had experience of traumatic events. Now, people can say can read the textbook and come into a psychiatrist's office and give you a very good account of all those symptoms. whether they actually have those symptoms or not in reality, or whether they're doing it in order to attain legal right to stay in a country or not. It's a very, very difficult thing to do. The military are far better at doing these more longitudinal assessments, so spending a lot more time seeing the person over and over again, and the military are a lot more cautious about making the diagnosis too soon. For obvious reasons, compensation and losing manpower, but it's very sensible that it's done in that way. And often in civilian practice, we're a little bit too quick to use the term post-traumatic stress disorder when really a lot more time should be given to the assessment process. So what have the military done in recognition of the lessons learned? Now we're on deployment. Everyone has access to a TRIM practitioner. That's a trauma risk management practitioner. That won't be someone with a medical background. That will be someone within the ranks with no medical training who has some basic understanding of how to identify and signpost someone amongst them who actually might be showing the signs of mental distress. They don't have to be able to diagnose PTSD or any specific condition. They just need to be able to pick up that there's someone here in front of me who needs further assessment and treatment. So everyone will have access to that. We do deploy field mental health teams. These are predominantly nurses by background, but have skills in not just assessing, but also delivering therapies out in the field. EMDR, I've mentioned that. EMDR is eye movement desensitization reprocessing therapy. Bit of a long term, but it's actually a NICE approved, so it's an approved treatment which most of the practitioners out in the field will be trained to give. This is something the military, again, do very well, because in civilian practice, if I was to see someone with PTSD in my clinic, accessing EMDR therapy for them is very, very difficult because there's not much access to such therapies. But again, the military do that very well. Now we also, on deployment, we understand on the way our troops are brought back, there's a need for decompression, and also access and availability of signposting when they come back, because sometimes these things remain latent for some time for people. And it's only later, once they've returned home, they've had time to stop and take in what they've experienced, that they sometimes start to realise they've experienced a mental difficulty of sorts. And certainly even now that the Army is moving towards a greater force of reservists, we know that reservists are more susceptible to mental health disorders as opposed to our regular personnel. So really looking forward, the Army are really looking towards enhancing all of our mental health services, particularly out on the ground. So what do our men and women have access to once they return, not just out on the field? Well, Role 4, that's definitive medical care back in the UK, and that includes rehabilitation. Our men have access and women have access to that. The Royal Centre for Defence Medicine and the Defence Medical Rehabilitation Units are also services that are available to them. Now, unlike in civilian practice where rehabilitation for physical conditions and often mental health conditions kind of sit apart from each other, the military are much better at integrating these services. So within the military rehabilitation services, these will be teams which consist of both types of professionals. So it's a very holistic treatment approach to rehabilitation. I'm only briefly touching on veteran services because it's probably a talk in itself, and it's a very evolving area. And something which I think politically is also something which is very debatable, and there's a lot that needs to still happen than what just has happened in terms of veteran services. Veteran services are very differently provisioned really across the country, and there isn't really any consistent system by which these services are provided across the country. They will vary greatly. In the recent years, there has been a lot of investment and money made available for veterans charities, and if you look up on the internet veterans mental health services, you will find literally thousands of different services, charities that are trying. What they're all doing, I'm not entirely sure, and some will be more credible than others. But the problem we have is across the board, there isn't a consistent and well-recognised type of service for veterans. Essentially, veterans in the Morrison reports recommended that each region should have a developed veteran-specific service. But he kind of left the recommendations as vague as that. So every region in the country has interpreted that differently. Some places have enhanced their normal civilian mental health services. Some areas have done other different things and just actually set up separate veterans services as well. So everybody has been left with a free hand to interpret that recommendation in whichever way they want. But one thing that we should all be aware of is the military covenant, which enshrines really society's duty to make sure the veterans do get the care that they deserve, given that they have actually served their country. And within general medical services today, within the NHS, someone who is a veteran should be known to their general practitioner, should be flagged up as someone who should get some degree of priority for care where it is possible. So just to kind of go through just very quickly is the NICE approved treatments. The NICE is, for those of you who don't know, National Institute of Clinical Excellence, and this organisation produces guidelines for treatment of a variety of conditions, including mental health conditions, which are all evidence-based. And this is what they suggest are the treatments we should be giving our men and women for PTSD. Trauma-focused cognitive behavioural therapy. CBT is I mean, I believe, a fantastic form of talking therapy, which is available for a whole gamut of psychiatric conditions, and really is probably the mainstay of treatment that's available, talking treatments for people with PTSD or anxiety disorder. There's a number of different sorts of conditions. Again, the military are a little bit ahead of the game in understanding the sorts of cognitive difficulties our men and women experience. When it comes to cognitive behavioural therapy, there's an understanding that PTSD falls in two camps. There's trauma-based PTSD, and there's guilt-based PTSD. By the description, trauma-based PTSD is someone who's witnessed a traumatic event, and as a result, experiences physical symptoms of anxiety. So will become shaky, will have panic attacks where they can't breathe, very physical experience of the traumatic event. For that, CBT is very effective because it's talking through the relationship between the thought process, the physical experience, and hopefully coming to some sort of resolution for that person. Guilt-based guilt-based PTSD, or survivor guilt, as some of you might know it, is a lot more difficult to treat using psychological treatments because it's not a physical experience of that traumatic event. It's the psychological experience of feeling guilty that you've survived and others around you who you cared about didn't. So that's a type of PTSD that's very resistant to any form of psychological treatment, unfortunately. We use medication increasingly because we know PTSD is associated with, it's a type of anxiety disorder. It's also a type of depressive disorder. We would use the same sorts of medication for the treatment of PTSD as we do for those conditions. And mental health support, again, similar to the veterans charities that I just described, mental health support will vary greatly depending on which part of the country you live in. If you're someone who's a veteran, but within the establishment of the military, certainly mental health support is available through our departments of community mental health, which are dotted around the country, which even our reservists have access to following a deployment, providing their mental health disorder is felt to be linked with their service. So in summary, before I allow you all to, if you want to ask any questions, what did I conclude from having done spent a bit of time researching this topic is, unfortunately, our memories remain short when it comes to things that we learn from conflicts, because each time we have a conflict, we learn lessons. And it seems to be when the next conflict comes around, we've forgotten what we learned from the previous conflict, unfortunately. So it's evolved, and each time we've had a conflict, the type of mental health disorders, the way in which they're presented have depended on society at the time, the type of warfare, and therefore in years to come, how mental health problems will develop and whether we'll still use PTSD as a term, who knows. War has been a time of great change and a lot of experimental treatments, particularly in the early years, were used, which actually have changed the way we practice psychiatry. And also, really, even today, it's an evolving specialty. Mental health, military medicine continues to evolve as time goes on, really. So just to give you a little bit of a background to the books and the references I've used, particularly the second book, reference there, if anyone wishes to read, it's an excellent read. Bit of a thick book, but beautifully described various aspects of World War I and II in particular, and various battles and the consequences in terms of mental health services and therefore from there. Well, thank you very much for your attention. I hope you've taken something away there. Thank you.